Our guest is in the studio. She is the Cabinet Secretary for Health, Dr. DEBORAH Barasa. Good morning, Dr. Ari.
Good morning, Eric. Good morning, Du.
Karibu sana. That's the hot seat of the Situation Room. It's good to have you here.
Thank you. Thank you for having me.
Yes. I can see you are well.
Yeah.
You are healthy. We are also well.
Asante.
As far as we, to the best of our knowledge, so far, we're healthy.
Touched the forehead for now.
We are healthy. Our colleague City Muga would have loved to be here, but he's away. He usually goes to one African country and he mines proverbs from that country, and then he brings proverbs from that country. One proverb a day. And when we have a guest in the studio, we tell the guest, listen to the proverb, give us your own interpretation of that proverb, and tell us what you think. This week, City said, let's go to Libya. Libya, as you know, is called the State of Libya. It is a unitary republic under a provisional government. So since that thing that happened and Muammar Gaddafi was done the thing that he was done, they've not had a stable government. They've been having a provisional government. And the chairman of the Presidential Council is called Mohammed Al-Menfi. The vice chairman is Musa Al-Koni. They have a prime minister called Abdul Hamid. And they have a speaker of the house called Akhila Saleh Issa. And the legislature is the House of Representatives. Of course, the capital is Tripoli. And there are those that say that even Benghazi has a claim to it. But we go with the official one, which is Tripoli. Now, the proverb for today from Libya is a very simple and straightforward one. If you listen to it, I'm sure you'll get it immediately. He howled before going mad. He howled before going mad.
Okay. Well, I think for me, it sounds like where there is smoke, there is fire. So, yeah, we start looking at the signs, before now, something comes up. And I believe that, indeed, even during this time, coming from the medical background, we have seen a lot of people suffer, a lot of people die, especially the needy, the vulnerable, the low-income earners. And in terms of health insurance, most Kenyans don't have a health insurance. And so for me, this is really a time for us, seeing that it is part of the government's agenda to implement universal health coverage and to ensure that all Kenyans have affordable, accessible, quality care. So before he gets mad, let's do what? Let us ensure that things are settled, or before, things get out of hand, before we have high mortality, before we have people dying, people having illnesses, and donors may be pulling out, there's Hamas, so there's shunting of funds to other countries. And as Kenya, even as Africa, we need to have sustainable solutions in terms of financing, and especially for health financing. We need to stand on our feet. We need to be stable. We need to be self-sufficient, and we need to have sustainable solutions. And so this actually resonates with the discussion today on UHC.
The country is howling. We do something before it goes mad. Waziri, the issue of universal access to health has been a conversation in this country for years. Attempts had been made. In the previous administration, there was an attempt to roll out UHC. There was a pilot that was done. There was a strategy that was being developed, stopped. The Kenya Kwanza administration came in, said, let's relook at how this thing is going to be worked on, came up with laws, bills were taken to parliament, they were passed. October last year, President Ruto says, now we are launching UHC. Because we have the laws in place, now it's implementation phase. We have been in that conversation since October. Oh, Mara, it's July. Mara, it is September. Now we are coming to October. Where are we in the rollout of UHC? Like, finally.
Thank you for that question. So maybe I should start with what UHC is all about, so that all Kenyans understand we need to walk the journey with everyone. We need to own it as Kenyans and see what is in it for us. What are the benefits? And when you look at the model for universal health coverage, it's all about affordable, accessible, quality care. At the community health level, we have the community health promoters. They are at grassroots level. They are the ones who interact with the community. They are important in terms of prevention and promotion of health within the community. They are able to identify pregnant mothers so that they can start antenatal clinics and then ultimately prevent maternal death. Again, they are able to identify children with malnutrition, those who have not been immunized, so that we don't have high death among the children. Again, diabetes, hypertension, and other health education, including emerging and re-emerging infections within the community. So now they are the first contact. So let's take a patient's journey. The first place the patient visits is the primary health care, our dispensaries and our health centers. And previously, as you know, there were challenges in terms of health products, human resource supporting these primary care networks or primary health centers. And so patients would move right to Kenyatta Hospital, or other high hospitals, overloading them and overburdening them. And so we looked at strengthening this area, and in terms of products and in terms of human resource. And what the model also looks into is that after having the health insurance, just like the Linda Mama, a claim is sent, and the resources come back to the facility, and so the facility is able to capacitate itself. So you saw Linda Mama with the kind of funds they were receiving, they were able to capacitate the primary health care. They were telling me, we bought equipments, we were able to have increase some of the support staff, etc. So how about SHIF, or how about the universal health coverage? What we are doing, as you are talking about the loop, this is also a cycle, a vicious cycle, where we are having resources back at primary care level to capacitate it. Now, let's say this patient is referred. Maybe they have a complication, maybe kidney disease, cancer. So they are referred to the higher levels of care. So at this level of care, such conditions are called conditions that have catastrophic expenditure. When you're started on dialysis or you have cancer, what happens? People sell land, they sell their cows, they sell everything. And the challenge with that is that you deplete your resources. And I always remember the story of a man I saw in Kenyatta National Hospital who was on dialysis. But thank God, at one time he had a health insurance. But during my study, I saw how he took his title deed and he took some of the properties and he was giving it to his wife. And what that showed me is that he's giving her so that maybe they can secure a loan or they can get finances for him to go through dialysis. And that was heartbreaking. Actually, when I saw the man the first time, I thought he would die because he had difficulty breathing, but he went for dialysis and he was stable. Now, a few months later, and even as I continued in my Masters of Medicine, internal medicine, I still saw the man. So I was wondering, how much has he sold in order to access these services? And ultimately, suppose he dies, or suppose he's depleted of his funds, what happens? He won't afford dialysis. He will die.
That's it.
And then he leaves his wife as a widow, the children as orphans, and they have nothing. And that is the reality. So when you go to a private facility, even right now, if it's an ICU case, you're being told 200,000 deposit. Where can we get that money? So at that level 4 to 6 is where people are having catastrophic expenditure. And so, and previously, when you look at the NHIF model, it was incorporating the employed, so 4 million, more than 4 million households, and then the poor and vulnerable were also could also access. But now we are saying all Kenyans need to access care. You never know when a disease will be knocking at your door. You never know when your relative will be needing the care. And how do we have that health financing? We cannot always depend on donors. It's all about us bringing to the table, contributing as Kenyans based on our financial capacity or our financial muscle. And so that is the model. And you can see previously NHIF, anyone earning 500,000 and above would only pay 1% of their salary. And yet a person who earned 30,000 and below, 5%. You see? But with this model, that was called a regressive model. The progressive model is about your capacity. So it's a percentage of your capacity. So level 4 to 6, we want accessible, also affordable, quality care. And this is through contributions from all Kenyans.
Right.
Yeah.
Waziri, all those things that you've said,
Yes.
completely true. And everybody in the country agrees
Yes.
that there is need to look at how we can all access healthcare better, more affordably. And that it doesn't cost us, and that we have the best quality that we can get.
Yes.
So far, yes. Government says, let's roll out this plan, and this plan is the one that's going to solve the issues. And where Kenyans have been is, okay, but how? And when? So there's been a conversation about when the UHC will roll out. What's the difference between the NHIF and SHA? And we've had the chairman of SHA, we've had director Dr. Matende Chero and others from the ministry coming here to explain what SHA is, the advisors of government in the ministry, the PSs have been here. So we had the conversation about SHIF SHA. It's about now the implementation where people are going to see this is the actual difference. And so the question comes back again. When are we starting the rollout, proper rollout? We know the CHPs were hired, they've been in the communities. The other rollout of this UHC, when does it begin?
All right. So the rollout is anticipated for 1st of October. So that is the rollout. And maybe to just inform you, what we are doing currently is ensure that all the facilities are capacitated. So we will start with the ones that have been offering NHIF because they already have systems in place. So we will incorporate the platform, the digital platform, where the claims will be, requested and also processed, as well as the registration platform. So this
are these new platforms?
Yes, these are new platforms. Yes, so it's a whole topic in itself. It's about digital superhighway. So what we are starting with is called a minimum viable product for claim processing. Yeah, but ultimately what we are looking into and what the plan with the consortium is about building a digital superhighway where we are having, various, like the community health promoters information incorporated there, the KEMSA, the health products, supply chain is monitored, tracking of products. Again, the issue of human resources to ensure that all facilities are well capacitated and the doctors are also licensed. Again, to look at the health facilities and the health service delivery that is there, and issues of infectious disease surveillance and other surveillance that would cause health security, among others. So it will be a comprehensive a platform where it's, again, interoperable, so you can see patients the same. Records are in Nairobi, they are in Coast, they are in Nyanza, etc. So that there's interoperability, but again, there is protection. So now coming to rollout. Rollout is about preparation. Launching is on the 1st of November. Now we are rolling out. We are ensuring that the devices are in place. We are ensuring that the health workers have been trained. We are ensuring that even the claims people, anyone who's going to be involved in matters of health is trained, and the devices are there. The systems have been incorporated in preparation. Again, the transitioning. We are transitioning the NHIF clients. So currently, we have more than 4 million households, and so we intend to transfer that. So that's around 10 million to 12 million. Again, we have the indigents, or the poor and vulnerable, as identified by the Labor and Social Protection Ministry. Again, those will incorporate, and equally with the children. So through the education, and those ones, we can link up and see what family, because part of it is you register as a parent, and then you will put your dependents thereafter. So again, we'll get a good number. So we believe that before the launching, this is the rollout where we are now taking the steps towards the launching. We believe that we'll have enough Kenyans enrolled or registered before now the actual launching.
Okay, Dr. Barasa, so what happens for still seeking care? Because we understand that obviously there will be a migration,
Yes.
right, from one system into another. But what happens for folks who are seeking care in the interim? I really have to go present myself to hospital and be treated while this is being rolled out 1st October, 1st November. What happens? We also know that folks are currently registering and there's already hiccups here and there. What happens to ensure that there is no stoppage of provision of healthcare for folks who have previously been registered and paid up on NHIF?
Wow, that's brilliant. And actually, that's where we are. We are at the transition. And you are very right. Even coming from the medical background, I'm always thinking that man going for dialysis, that woman who wants to deliver, who's almost delivering. We need to ensure that the transition, and that is the sensitive area that we are ensuring. And part of it, what we're doing is communication. We have materials on transition for NHIF clients. We are communicating through the media platform, using the community health promoters, using the Ngao our colleagues. And what we are encouraging Kenyans, please, the services are ongoing, so you can access the services even as we migrate. And then for NHIF, what we are doing is that there is an SMS that will probe you, informing you that we are transferring you. So there is no way, there's absolutely no way that an NHIF client should stay at home. They should just visit a facility and they will be informed. So the services will be continuous. They will continue even as we transition. And that is an area that we are keeping an eye on and monitoring to ensure that the NHIF clients are accessing our services.
The health provider
Yes.
in these facilities, does he know this? Do they know this? Do they know that we will still accept NHIF members for the month of October?
Yes.
And do they know how they'll get paid? Because everybody knows, so NHIF is coming to an end and we have a new entity that's going to come in. We are at the point of transitioning. In this transition period, what communication have you had with the health providers, with the service providers, the facilities, the hospitals, to be guaranteed that their money will be paid? You see, they've had issues earlier this year where they were saying NHIF has not paid us for very many months. There are very many arrears. How have you dealt with that?
Yes, indeed. We are looking into that issue of supporting or paying the NHIF debt that is present. So that is something that we are looking into as a ministry. And what we are saying is services need to continue. Healthcare services need to continue. For health, it's a sensitive matter. It's about life and death, unfortunately. So we need to ensure that there's continuity of services. We have engaged partners. We have engaged the private organization, faith-based organizations, the ministry. We are, as I said, yesterday was the last day when we had the national trainer of trainers. Will cascade into the regional to county level and down to facility level. And so we anticipate in the next 2 weeks, the information should have reached all facilities. And we also expect that the system will be incorporated in the next 2 weeks. And then after that, now we will be able to ensure that everyone is trained and there's a seamless flow before now the launching on the 1st of November.
Several institutions or associations. One is the Rural Health Providers Association, RUPA. The other one, the Private Health Providers Association. And also now looking at the Faith-Based Providers Association. Those ones had issues earlier in the year, where they had even said, we are no longer accepting NHIF because of the arrears. As we sit here today, Waziri, can you say that none of these associations would complain of arrears with NHIF, that they are comfortable with NHIF as of this morning?
That is Yes, thank you for that question. We had a lot of challenges with NHIF, and you remember the corruption, even the audit that was done quite recently, and also coming from the medical background, you see, there is one hospital in particular where you remember that the knee it was a very small hospital, and they had more than 50 knee replacement surgeries in a day, which is impossible. And it was even higher than Kenyatta National Hospital. So there were challenges in terms of service delivery. They were misquoted and overpriced in terms of products, in terms of patients. You know, you could hear that the patient is in Coast, the patient again is in Nairobi, and the claim is being sent. Again, there were issues with them. There were many issues from facility to provider to patient level and up to NHIF. And I believe those were the challenges. And through the digital platform, you know, we are trying to minimize corruption. So at patient level, what are we saying? We are using biometrics, and these biometrics are actually, matched to those of NRB to ensure that the patients are the same. Why is that? Because they were using different fingerprints. So you could have the manager of the facility is using his fingerprints for various patients within, you see? So that was a point of corruption. But in this case, we are saying that before you are seen in a facility, we take your biometrics or you get an OTP. Again, what happens is there is a message that will always come if you went for, any surgical procedure. So if it's not the truth, then you can always follow up on that. Now we come to the health workers. Again, we had multiple claims. You're hearing a surgeon is in various regions. But in this case, we are saying once you log in, you cannot log in to another region. So the healthcare providers, and then we ensure that if you are a practicing clinician, then you need to be registered so that we are having the best or offering quality to our patients. Again, at facility level, as we said, the capacity, the health service delivery within a facility, we are able to map out and know what can they do and what can't they do. So you see, we are fighting corruption gradually as we move up. And equally what we said about the supply chain, tracking medicine and ensure that it reaches the last mile. And I know one of the questions Kenyans are asking is about tenders and open tenders. One of the things that will be done is that at KEMSA level, we'll be able to see maybe this manufacturer is selling Panadol at 8,000, this other one at 100, this 50, 1 shilling and so on. So we can see it's transparent, it's visible to each one of us how the products are, and then we'll be able to monitor quality so that whoever is providing for us is accountable, is held accountable. So this system will fight corruptions in multiple ways. And that is why I would like to encourage even the faith-based organizations, the private institutions. We are working gradually to ensure that we are fighting corruption. And one of the greatest achievements that will come, that is coming, we are starting with the minimum viable product, but gradually we'll improve it, is the digital platform.
Even with the rollout of UHC, I believe if we look at a couple of years ago when UHC started to become a conversation and there were pilot projects that were done, we looked at Isiolo, Nyeri, Machakos and Kisumu. And some things came through that facilities were an issue, and in terms of everything that was needed to deliver service. And if we look at some of the other issues that come about through a doctor's strike, is that sometimes equipment is just not available, that there are no staff, essentially because enough people have not been hired, that we don't have doctors who are paid what a CBA, for example, has required. And all of this, if we can say it, is a loop. It doesn't matter where you look. That in order to deliver UHC, in order to deliver what we're saying will roll out in the next couple of weeks, there's certain brick and mortar elements that don't exist. And so the question is, can you really then deliver UHC if there is non-existence of some of these elements that are absolutely vital? If there's a long line at Kenyatta, for example, if there is a facility somewhere in Garissa whereby, we can't access it and somebody still has to come all the way to Nairobi to get it done, can we really deliver UHC without some of these things in place?
Wow, thank you so much, Ndu, for that. And for me, I believe it's one step at a time. When I saw it in Machakos with the UHC rollout, it was brilliant. It was marvelous. I think we just need to believe in ourselves as Kenyans. We need to unite to deliver UHC. So at primary care level, what we have done is conduct assessment to identify gaps. When you look at the benefit package, it is a bare minimum based on the finances. Following the finance bill, what happened? We were given limited resources. But we said we are not stopping there. Let us progress. Let us give Kenyans a bare minimum package that they can access at primary care level and other levels of care. And so I think it's one step at a time as we capacitate. We have been able to deliberate, and we have raised it even to the higher levels and to KEMSA level, and resources have been provided to ensure that medicines are available. We have mapped out the capacity, and what we have in terms of human resource at the moment is sufficient. And so gradually, assessment will go on, capacity will go on, even as the resources avail. And as I told you, the Facility Improvement Act, as you looked at it, it's all about capacitating the facility. And this is looking at sustainable solutions, you see. So we may not be perfect at first, but let us think of it as a gradual process that ultimately we are aiming to have sustainable and self-sufficient.
Here's the thing though, Waziri.
Yes.
Okay? You identified the problem, even in your own statement at the beginning of this interview, that people would have a matter that could have been handled at a healthcare or a dispensary going to a level 4, 5 for same care. And the focus now is let's deal with preventive and primary care. And with preventive and primary care, we want to encourage people, you have a headache, go to your local health facility, local dispensary. And then from there, we start the issue of now graduating upwards, or even coming from up and graduating down. Those facilities at the local health center need to be working for this to work. That is 100% taxpayer funded, the primary health. Is it ready for 1st of November? Can we say that on the 1st of November, from the Ministry of Health, from what the studies that you've conducted since time immemorial, even now with a plan for the rollout, that if somebody has a minor headache, it's an injury, they have been throwing up, their child is sick, if they go to a local dispensary, they will actually be able to be attended to and go back home?
Yes, so that is what we anticipate. Currently, we have 109 out of the 350 primary care networks having been capacitated. And yes, the products are, we've been having challenges on health product delivery, but what we look into in the next coming weeks is accessible products or medicines for people, again, a human resource. So we've been able to map, and those are now the interventions that we're putting in place, even as we look to rolling out the SHA, the Social Health Authority, on 1st of October. And as you said, we need a sustainable solution. You see, the over-dependence on treasury can be a challenge. Yeah, and we have learned that through the finance bill. So as the Ministry of Health, what is sustainable in terms of health service delivery? It's having that contribution routinely, a good amount of money that can, Kenyans can utilize and have access to affordable quality
I hear
care.
you, Waziri, sorry to interrupt, but the contribution to the Social Health Authority, Social Health Insurance Fund, is for the middle level care, right? And you do not want to deplete the middle care with things that should be sorted at primary care. So to make sure that SHIF is not spending money it should not be spending, primary care needs to be working.
Yes.
Is it working?
And we are capacitating. That is actually, when you look at the acts, there's the Primary Health Care Act and the Facility Improvement, Social Health Insurance Act, and Digital Health Act. So the Primary Health Care Act has clearly articulated the roles, responsibilities, and the capacity for the primary healthcare level.
Yes.
And so we want to make it fruitful and have it even as a primary care network with good referral systems within the public. Because
True.
Yes.
That's the basis for my question, because the law provides that the Primary Healthcare Act says primary health shall be working, it shall be funded through the National Treasury.
Yes.
Then there's this middle care, that is the social health. And then there's a critical, emergency, and chronic illness fund that will sort out the person with dialysis. Are these things aligned? As we head towards November is only how many days? 60 days,
60 days away.
Yes.
70 days from now.
On November 1st?
It's actually
40 days.
40 days away.
So for primary care, we can assure Kenyans that yes, we have the resources available. And for emergency, critical and chronic illness funds, what we can assure is the emergency. Even when you look at the package, the emergency component, and we are looking to on the critical aspect of the funds. Now, for the social health insurance, as you well know, it depends on the contributions at hand. But now that we'll be able to transfer the clients from NHIF to SHIF, I believe that would be a good starting point. But now we need to onboard more Kenyans so that they contribute, that we can have sufficient resources for it to be sustainable.
Let me ask a practical question. Maybe we can answer it that way. If I am in Chuka Town today, and we're looking at the primary level, and I go to a dispensary or I go to that, level 1, 2, 3, seeking care, what we are saying is that the rollout today will ensure that I walk into a facility with my headache or whatever it is may happen, and I get treatment, and I leave that hospital or I leave that dispensary health center in Chuka without spending a dime, and I'm treated and I go back home. That will happen now?
No.
Okay.
So, those are the challenges that were there before. And what we are assuring Kenyans from 1st November, that is what we're working towards. So resources have been released, and we believe that KEMSA will be able to distribute to the primary healthcare level resources. And human resource will also be available. And as I said, it will not be a one-off. We are really working to strengthen the health system in Kenya. And for the digital platform, it will be able to tell us about the capacity. What are the health products in each facility? So each county governor, and even at national level, while we are seated there, will be able to map out and say, these are red, danger, we need to bring products there. These ones are green, they are good to go, etc. And even in HR capacity, we'll be able to monitor how the nurses and the doctors, how many are present. One of the challenges or the governors were talking about is at times you may have a doctor has been employed but has done maybe 5 surgeries in 6 months and so on. So then it brings challenges. But with this system, we'll be able to monitor and ensure that services are delivered and Kenyans are getting quality. Because the ultimate goal is for us to have a system that is it's the same as our private facility and faith-based. And so it may not be perfect, but as we continue with assessment, as we continue and strengthen the digital platform, we continue with engagements, we'll improve the intergovernmental relationships. I believe that within a good time period, we should have this system ready. So it may not be perfect at this time, but we are working on it.
What's the thought about making sure that the system, at least to a certain percentage, is foolproof before asking Kenyans to then start to use it?
Yes. So we have engaged the Data Protection Commission. We have looked into the cyber security concerns. We have had layers of protection for each component and again for the whole digital superhighway. So, and then the cyber security concerns are being addressed among others. So that is indeed an area that is of great focus, and also borrowing from the e-citizen and other platforms. So definitely we look into ensuring data protection.
So you've come into office where certain things were happening. You know, the doctors had just come off a 50-day strike. Was it a little bit more than that? And just last
clinical
week,
officers,
clinical
100 days
officers,
plus.
100 days. Nurses did their bit. There's still a lot of dissatisfaction around the human resource aspect of healthcare delivery for doctors, whether it's at the county level, whichever level it is. We just had this whole debacle with interns and whether they will be paid what is prescribed. How you deal with that human resource aspect? Because year in, year out, it has been an issue. Doctors today are threatening that I believe they've given a notice. They will go on strike again. How do we deal with some of these issues whereby we just never seem to be able to agree and sadly do the right thing?
Wow. Ultimately, let me start from ultimately, yeah? When we have the social health authority in place, what that means is the facility will be able to capacitate itself, and gradually we believe that it should be able to pay the human resources within that facility. Yeah, so that is the vision, that from primary care level up to level 6, they should have enough resources to maintain the human resource. That is the ultimate and the sustainable solution. But for the human resource, we have an act that will be coming very soon. And again, we are working on the HRH policy. So all those things will be well articulated to ensure that we are addressing the concerns of doctors and nurses and the clinical officers, basically all the cadres that are involved in healthcare delivery. So this is an upcoming policy, and I think I believe that we'll have a lot of participation to ensure that all the concerns are covered, especially for interns and also for doctors. But for the doctors, I believe it has been sorted by now because resources were released, even as we continue with them. And equally the nurses and the clinical officers, we are addressing the issues and ensuring that their concerns are addressed and the CBA is adhered to. During
vetting, you pledged support for the establishment of a Human Resource Commission. Tell us about that.
Yes.
Medics have been pushing for this, for a one national commission that employs them and deploys them. Do you still, after now gone into the ministry, talking to the officials there, do you still think that this is the route to go?
Okay, so for our constitution, you know that it is very clear that health is a devolved function. So that is where we are as a foundation. And so our work is to strengthen that intergovernmental relationship to ensure that the human resource concerns are addressed at county level. But I hope to again engage the governors, because there are certain subspecialists like a neurosurgeon. We don't expect a neurosurgeon to sit in a facility the whole day. He might maybe do one surgery in 3 months. Yeah. So for him to improve his skills, for him to serve more Kenyans, we may need him to go to multiple counties. Equally for those critical but really subspecialized courses like urogynecologists and gynecologists, among others. So there'll be deliberations on how we can have this as a national resource or a regional resource so that they can serve various counties. They are very expensive. We don't want them to do work of a medical officer or a clinical officer. We want them to improve their skills and be able to serve as many Kenyans as possible. So deliberations on that will be ongoing with the governors to ensure their buy-in. Yes.
Let's talk about Mpox, because now there's something that your ministry is now dealing with. There's a threat of Mpox in the region, threat of Mpox in the country, right? And we've been seeing lately, there's talk of, the government, your ministry, setting aside a certain amount of budget to just deal with the threat of Mpox, or saying this is how much we would need to deal with Mpox. Talk about that.
Yeah. Thank you so much. So the State Department of Public Health and Professional Standard have developed, that is a State Department, a response plan. But as you know, it is critical for us, first of all, to have a response plan, seeing that this is a public health emergency of international concern, of continental concern. We need to be, to work towards having a prompt response plan. And so the State Department of Public Health and Professional Standard went ahead to develop an urgent response plan. But ultimately, we want a comprehensive plan that involves both public health and medical services, because of continuity of services, because of co-infections with other, like HIV among others. We've seen it in other countries within Africa and beyond. And again, we need a ministerial approach, because this is a zoonotic illness, so we need vet medicine colleagues involved, wildlife involved, and again we need the health security, because this is a health security risk. So a comprehensive plan is anticipated. So the plan, again, we are reviewing to ensure that it's comprehensive and consolidated, and ensuring that it is aligned with the budget at hand. Yes.
Okay. There are some, I'm just looking at that, of course, when we're dealing with a threat such as that. We did have a conversation about this with the Department of Standards, Professional Standards. But as we come back to, I just want to look at the system again. Folks are registering, and there's an issue at the moment that you're not able to register folks who are of a higher age, 70s and above, within the system. Is that a bug that can be looked at?
Yeah.
I don't know if you've heard that this particular problem exists.
Yes. We are looking into all those concerns, and that is why this time is the time when we are monitoring. We are having input from the healthcare providers and the users of the system.
So I'll give you the example of the exact problem.
Okay.
There are people whose ID begins with 0.
Okay.
They are not able to register,
Yes.
and the response that the system gives is that you must go get another ID and re-register. I don't know how you can do that when you're seeking healthcare, but that's the bug response from the system.
Yes, we are working on that.
Whose system is this, Waziri?
It is a Safaricom-led consortium. Yes.
So who's in the consortium? So is it Safaricom's system, or is it the government system?
Safaricom is a government agency.
No, it's not. It's a private entity with government shareholding.
Yeah. So yes, there's the government component to it. So Safaricom, it's a Safaricom-led consortium. Yes.
So what is the role that Safaricom is playing here?
So they have an MOU. Part of it, I think, is in terms of data connectivity. They are also supplying some devices. They are helping in the development of this digital superhighway and supporting in training, among others. And it's all about sustainability, and that's possibly why we had Safaricom identified at the time when my predecessor was there. So looking at sustainability and housing such a system within Kenya.
So these facilities then, the gadgets that are being distributed, the server that is holding the information, is it Safaricom's servers and equipment, or is it the ministry's equipment?
Oh, that's a good question. It should be the ministry. So it's coming from Safaricom, but now it will be owned by the ministry.
And the people who are holding the data right now, who are inputting the data, like you're saying, there's a lot of coordination of inputting data and all this. Are they ministry staff, or are they staff of this consortium?
So now there's the system development and there's data input. We are at system development. So the system is being developed by the consortium led by Safaricom.
Okay.
But when it comes to data input, it's our healthcare providers who will be doing that. And
I see.
Okay.
Waziri, our time is up. It's a short one, but come again soon, please. As we get closer to October, during the month of October, when now you're stress testing the system, and then we launch it in November, please, let's have more engagement so more people can hear and understand what they need to do.
Okay, so maybe just to close, thank you so much for having me. I didn't have time to talk about my vision, but I hope next time we'll talk more about the vision. And I believe the first and the primary is the realization of UHC, because if all Kenyans are able to access affordable and quality care, I believe it is going to be fruitful for us as Kenyans. And again, looking at the health infrastructure network, when we look at the level 6 hospitals, I believe that it's important that we have equitable distribution so that we have our level 6 hospitals all over. And really, that speaks to accessible care. That's because true. I think care has been centralized more in Nairobi. We have 5 of the level 6 in Nairobi and then 1 in MTRH. So how can we ensure equity so that Kenyans can have access to care at northeastern, coast, eastern, and among others? And in this level 6, we need to think about medical universities, specialized training for nurses, the doctors, training of even for other cadres, referral, strengthened referral systems, research, innovation,
there's a lot.
Centers of excellence.
So come back. Come back. We actually look at what's your plan going forward. And we'll also tell you, we had an interview here with the healthcare practitioners, and they said this is our wish for our new minister. Awesome. Dr. DEBORAH Barasa, Cabinet Secretary for Health. Thank you for joining us.
This is the Situation Room, the only way to start your day.